So good afternoon and welcome to this webinar hosted by the Abionic entitled Real World Evidence for Implementing PSP Measurements at the Point of Care, Advancing in Diagnosis of Sepsis in Intensive Care Units. So my name is Pedro Póvoa, I'm from Lisbon, Portugal, and I'm a full-time intensivist in one of the big hospitals of Lisbon, and also professor of medicine in Nova Medical School, University of Lisbon. And I will be the moderator of an excellent faculty from different countries. I will start presenting Professor João Gonçalves Perreira from Hospital Vila Franca de Xira, and also professor in Nova Medical School, the same university as I am, and he is going to speak on using PSP to improve clinical practice. Then Professor Guiseppe Castellano, that he is a nephrologist in the Department of Nephrology, Dialysis and Transplant in the Ospedale Maggiore Policlinic in Milan, Italy, and associate professor at the Faculty of Medicine and Surgery of the University of Milan. Speaking on PSP in the middle of COVID-19 pandemic, a practical insight into potential clinical use case. And finally, Dr. Maria Petraki, that is the director of the ICU and High Dependence Unit of the Mediterranean Hospital in Athens, Greece, will speak on the Abioscope and PSP as a point-of-care solution in a boutique hospital in Athens. So, we know, just before starting a short overview of the problem, sepsis is a very, very frequent disease with a very high mortality rate. In the world, roughly 50% of the patients with sepsis will die. But also the problem is the survivors will have also long-term outcome problems, and the children are also affected by this, and sepsis is, at least in the most of the cases, a real emergency. But one of the problems with sepsis is to have a clear definition, because we want to treat the true positive case and identify the patients with infection among all the others, because we know that those that are the false negatives have an increased risk of death because of delayed therapy, but also the problem of the overdiagnosis, so treating patients that seem to have sepsis but do not have, they increase resource overuse, but also they have an increased risk of death because we delay the therapy of the underlying disease causing or simulating sepsis. And also it is associated with antibiotic pressure and resistance. So we need good diagnosis of infection, and the infection, the diagnosis is, let's say, an intersection of three vectors: the host response like fever, leukocytosis, tachycardia, organ dysfunction that is related sometimes with the organ is the primary source of infection, like central nervous system or the lung, and then the microbiologic identification, but we don't have a gold standard to identify infection, and sometimes the diagnosis of infection is delayed because those cultures took time. And there are till now more than 250 biomarkers described. The publications are rising every year. The number of new biomarkers is decreasing, but the majority of the biomarkers are much more prognostic related than the diagnostic related. And most biomarkers in the management of septic patients are not well defined, and only a few have been evaluated in large studies like CRP and PCT. And according to this paper, it's not possible yet to draw any reliable conclusion about which biomarker could be considered the most promising, but far from the ideal, because we did not yet find the ideal biomarker. So I will give the floor to the speakers, and then so we would like to know how they will answer to this question: how can PSP help in the diagnosis and measurement of sepsis in the ICU? And so I will give the floor to Professor João Gonçalves Perreira. João, please.
Thank you very much, Mr. Chairman, I will start in a few moments to tell a little bit about how to use this new biomarker, the pancreatic stone protein, to improve my clinical practice, and how to use it to address the septic patient. So let me just see if I can put on my slides. Not yet. Oh, okay. So sepsis is a complex disease. We all know that, and we have all those stuff like pro-inflammatory cytokines, anti-inflammatory cytokines, and we have the problem of organ dysfunctions and recovery time, the use of antibiotics, and all this interaction between all those stuff. But from the clinical standpoint, the most important thing is the patient himself. And what we have in clinical practice, the patients usually arrive in the emergency department, or we see the patient in the ward, or even as an outpatient, and we have a suspicion of sepsis. And a full microbiological workup is usually done, and start an initial antibiotic therapy, usually empiric antibiotic therapy. Then we have to evaluate the patient and decide when to stop antibiotics, when discharge patient home, or even back to the ward if the patient is in the ICU. And we have all those decisions to do according to our clinical approach. And what we usually also noted is that biomarkers can help us to improve our clinical practice and improve the certainty of our clinical decisions. And that's important not only to reinforce our role as doctors, but also to improve the patient's outcome. So how can biomarkers help us? To diagnose the patient, improve the diagnostic accuracy, but it's important to note that this role is much more important when we are in doubt, when we are really certain that the patient had an infection. The role of the biomarkers is less important, and when we have for sure that the patient is not infected, also the role of the biomarker is not that much important. But when we have a doubt, clearly the biomarker can help. Also to monitor the patient, the response to the interventions that we are doing, and even for prognostic. And most the prognostic role is more to select the place when to put the patient when we are treating him. Some papers also use it as a surrogate, but as you can easily understand, that may be misleading, and you have to be a little bit careful. Of course, it's important if we can use it in a timely fashion way. This point of care technology and give you the turnaround time can be as low as only 10 minutes. It's very important. Even if we are when we are in rounds or assessing a patient, if you can have a biomarker that can give you an answer in just less than 15 minutes, it's really useful to address that patient. If the biomarker only came back at 24 hours, usually that's benefit is not so much. When we want to address the patient, and the first thing that we already saw, it's important to make a diagnosis. Make the diagnosis most to rule in or rule out antibiotics, and to decide to perform cultures when we use it. So let's see our experience in my hospital with the pancreatic stone protein. And what you can see in this graphic, this is real practice, real life results. It's that when the biomarker, this biomarker has a high value, the probability of we actually will found, not at that time, but later on, we'll found a clear infection is very high. But with low values, the probability is much lower. I call your attention that even with very low values, we have some positive blood cultures. You can see it here. But these patients who have these results, and we review all those patients, and what we notice is that there were patients that have a catheter, a central venous line associated infection, and the central venous line was removed, and the patient really improved very quickly, even without antibiotics. Let's see how we use it in this clinical practice. Let's suppose this patient, one of the patients that we received, a male with 15 years, a COVID patient, and the doctors in the emergency department think he has also a bacterial community-acquired pneumonia super infecting the COVID infection. And what we do, we use this PSP, and we found that most of these patients have a very low value, and we withdraw or did not start antibiotics, and that was very safe, and they have not any problem with that. And in fact, in literature, what is published in this study that I think mostly of you already know, it's a meta-analysis, and what the authors found was that patients admitted to the hospital with COVID, only a very small number have really a co-infection, and even secondary infections occur a little bit more, roughly 15% of cases. But despite these low numbers, almost 3/4 of patients did receive an antibiotic and antimicrobial therapy that most of them clearly didn't need. So, and this, as Professor Póvoa already noted, is associated with an increase in antibiotic resistance, with the increase in the risk of secondary infections, and that's an important point to take in account. Of note, not all those patients were critically ill, but almost 7% have a critical were in the ICU and have a critical situation. And beside the point of increasing resistance, there is this sign. This is not a published study, but anyway, it's an observational study that noted that countries that more often the patients receive antibiotics when admitted to the hospital, the COVID patients, the larger the number of patients that receive antibiotic, the larger the mortality rate of those patients. Of course, this is only observational. There are lots of bias that can be present. Patients with more severe presentations more often have antimicrobial, receive antimicrobial, so it can be only an association and not causality. But anyway, it raises the problem that given antibiotic may not be so safe as we like to think. So, but of course, we don't use these biomarkers only to rule out antibiotics, also to rule in antibiotics and increase this certainty of a diagnosis. And in patients who we thought maybe have an infection, but we want to be sure, in 82% of those patients, the PSP value was high, even very high in half of those patients. And in some of them, we noted that have a focus that need to be controlled, mostly cholangitis. And when we control that infection, the PSP decreased very quickly, and the patient really improved. Because it's important to note that when comparing to other biomarkers, that the PSP may be the less influenced by inflammation, because the biomarkers, of course, are not there to diagnose infections. The biomarkers mostly respond to inflammation, and there could be other reasons for the patient to be to have this inflammation, like trauma. In this study, trauma was the one that was assessed, and as you can see here, the one that's most less influenced by I think I might have lost the control of the slides. The one that's less influenced, oh sorry, less influenced by the presence of trauma. The ones that were quite the same according to the presence or absence of trauma is PSP. And that's important because when the patient arrives to the emergency department, mostly we want to know if the patient really has sepsis or otherwise have an inflammation of other cause. And also, even if the patient has trauma, it's possible that the patient also have an infection, and we have to be sure, at least we have to increase the probability of that to happen. Another situation that it's very common in the ICU, it's the patient that is admitted for other cause or even for an infection. And during the ICU stay, we note that the patient have small increases in the CRP, have fever, and have, in the case of the COVID infection, have worsening oxygenation. And we want to know, does this patient has an infection? Does this patient has a VAP, for instance? And in fact, we think that PSP can also help in evaluating these patients. And in 1/5 of our determinations, we address patients like this, and in 1/3 we have a low value. Despite the patient has a suspicion of infection, we really have low values of PSP, and we're able to withdraw in most of them, not to start antibiotics, mostly not to start antibiotics despite the suspicion of infection that we were not certain. We have a suspicion. We use this biomarker and decide against the use of antibiotics in several patients. Because indeed the literature has there's some papers that have been published, and maybe this PSP have one of the highest sensibilities and specificities, and to be used in clinical practice, and maybe it's at least as good as other biomarkers to address those patients, and I think it's important to note this. We have been using it for about 9 months now, and we are quite satisfied with this, although we don't use it every day. We use it mostly when the patients have a suspicion of sepsis or an infection. We have to decide something, but the PSP really help us to decide this patient, over these patients. And note that at least in this study, even the patients with the more severe disease, the PSP also work quite well. A recent study also addressed the ability of the PSP to address patients before the diagnosis of sepsis. This paper has some limitations, but nevertheless compare CRP, PCT, and PSP to before the patients have an episode of sepsis, and compare patients who don't have sepsis with patients who have sepsis. And although this paper has some limitations, but at least there was a clear separation between those patients who with sepsis and not sepsis, even before the clinical manifestations of sepsis. And this is very important, as Professor Póvoa already told us. If you delay the start of the interventions, mostly antibiotic therapy or focus control, in patients with sepsis, we can increase mortality, and that's obviously a very big problem. Another possible approach is in using this PSP. One of them is prognosis, and prognosis in the emergency department means early admission to the ICU, but also some out-of-the-box approaches, because there are some strategies that do not work for all patients, like corticoids, like steroids, like beta blockers, clearly don't work for all patients, but maybe for those with highest risk of dying, maybe those patients would benefit. But let me show you, for instance, this old lady, 56 years, with cholangitis, all these little changes, blood pressure that she's not in shock, but has a low blood pressure, has a low platelet count, but not very low, no acidosis, small changes in the renal function with normal urinary output. So we really don't know if she really needs the ICU, and as you all know, the number of beds that we have in the ICU is limited. So how to decide if this patient needs to be admitted or not? And in fact, the PSP, at least in our experience, where it has very high values, is associated with an increased risk of dying. And so we think that this patient might benefit from an early admission. So PSP may also help us in the prognosis of patients. And we think, but we are not there yet, we think that it can be used in the emergency department when patients are admitted with a suspicion of sepsis and needs a very quick approach and to receive fluids, vasopressors, central venous line, antibiotics, you name it. But to discriminate those patients who might benefit from an early approach and or who have another diagnosis to overcome this problem of overdiagnosis. There are some literature that show that almost 50% of patients admitted to the ICU with a diagnosis of sepsis actually do not have sepsis. And to increase this certainty and to decide what patients really benefit the most, the PSP might really help, because in what we really need is to separate, to tell apart those patients who have inflammation but without sepsis, and those who really need the sepsis. That is, those patients who are really infected and have really an infection from the copy that may seem quite alike, but are quite a different story. Thank you for listening.
Thank you very much, João. Take time. So the discussion will be at the end. Please make questions through the questions and the chat. And now I will give the floor to Professor Guiseppe Castellano. Please, Giuseppe, go ahead.
Thank you very much, Mr. Chairman. Okay, I would like to present our data about the PSP in the middle of the COVID-19 pandemic, practical insight into a potential clinical use case. And actually, I'm at the University of Milano, but the work was performed at the University Hospital in Foggia, Italy. And in the department of Foggia, we have different high levels of care with a different type of patient in hemodialysis, in chronic kidney disease or acute kidney injury. And we have a different department organization, and with a number of beds allocated to the critically ill patient, and increased support for ICU in patients with the COVID-19 and acute kidney injury, with increased incidence of sepsis and superinfection. And we first show in 2020 in April in critical care that acute kidney injury was present in a high percentage in patients with COVID-19. And we described about 30% of incidence. And this high prevalence is due to a complex disease mechanism, because there are vascular consequences of SARS-CoV-2 induced coagulopathy with the activation also of the complement system. There is a cytokine elevation and a kidney invasion by SARS-CoV-2 entry in proximal tubular cell and podocytes. And this will give a multi-organ dysfunction leading to ICU recovery by our patient. So it's a very complex disease. This has been also showed that severe ACI in COVID-19 leads to worsened survival. In fact, patients with acute kidney injury requiring hemodialysis with severe COVID-19 are associated with a very high morbidity and mortality, with the extremely fast evolution that we notice in our department with the difficulty in the clearance of viral sepsis. And so these that are the worst situation, they need an immediate diagnostic need. And there is a need for a quick, easy to use decision making for to investigate the severity for this patient and to have a patient stratification that we think is really, really important. And these immediate decision-making tools are needed, and this can be done by a point of care system, as we know, that can measure biomarkers at the bedside of patient in our COVID-19 unit. This immediate determination of biomarkers from whole blood can accelerate, we think, our decision-making approach. We know that an ideal biomarker should be characterized by a high diagnostic accuracy, a predictive value, specific and sensitive to the disease, and quickly and easy to implement and assess. It has been shown that the pancreatic stone protein is a predictive biomarker for a multiple organ failure, and also clinical outcome is important information, as we heard previously. And this has been shown in several publications in a retrospective study, but also in prospective study, indicating that PSP is a predictor of sepsis-related multi-organ failure and death. And it has been shown in a high number of patients. The implementation in our unit, this pilot implementation in our unit, and today I will show our experience with PSP and the Abioscope. This implementation was done in our unit, and we measured of patient with COVID-19 nephropathy with the COVID-19 infection. So the pilot of the aim of this pilot study requiring hemodialysis, patient all with the SARS-CoV-2 infection with different severities of COVID-19 disease. The rationale to use PSP was that PSP is known as an early biomarker of sepsis, is a prognostic marker of disease severity in ICU patient. And also the advantage that PSP can be measured rapidly, quickly, at the patient bedside with a point of care testing from a small drop of the whole blood. And we analyzed 23 patients recruited in our university hospital in Foggia between February and July 2021. The measurement was performed within 24 hours after admission. So it was an acute measurement at the moment of admission upon arrival for hemodialysis and before the treatment. The PSP measurement was also performed in a group of ICU patients before and after hemodialysis and treatment with absorption treatment, as I will show you, for immunomodulatory cytokine absorption. We measure PSP due to internal organization issue, not in whole blood, but in serum. Therefore, we will have absolute values of PSP that are overestimated. This is the pilot design with 23 patients. We have 3 healthy control, 2 normal hemodialysis patients without COVID. So these are 5 patients that are non-inflamed. 6 patients on hemodialysis with moderate or asymptomatic COVID-19 that were admitted to our unit, and 6 patients with severe COVID-19 associated acute kidney injury. Then we measure the 6 patients in ICU, pre and post and immunomodulatory therapy for cytokine absorption with cytosorb. These are the patient descriptive, the characteristic, the feature of our patient. Again, the negative patient on COVID-19 in hemodialysis, the patient in hemodialysis with a moderate COVID-19, a patient in acute kidney injury in ICU. So what are the results? As you can see here, the COVID-19 patient that needed an ICU, they present a really significant increase in PSP level. And also these PSP levels were significantly higher in subjects who died. It is important to remember that this measurement was done in 48 hours from hospital admission. Then when we measure the PSP in a patient in hemodialysis again, but with COVID-19, these values were also higher compared with the patient in hemodialysis or healthy patient which do not have COVID-19. So it was possible to discriminate between the patient in hemodialysis that have COVID-19 compared with the patient in hemodialysis that did not have COVID-19 disease. And also between this year, the good discrimination between the healthy subject. So the serum PSP levels were significantly higher in patient than in COVID-19 hemodialysis subject controls, and also there was a difference in COVID-19 severity between COVID-19 in ICU with acute kidney injury and COVID-19 in a moderate situation. So these are preliminary results, but we see a trend for PSP to increase along with the severity of disease. These measurements were done on the bioscope, Abioscope, were easily implemented in the unit. Was really simple to perform this measurement and adopted by our personnel. So it was really easy to use, it's very fast. Whether the increase is due to the kidney injury or COVID-19 disease remains unknown, but we are looking with further study in it. What is also interesting to see is that when we use cytosorb in patients with intensive care unit, you can see that the level of PSP before the treatment was really high. Then after the treatment with the cytosorb, there was a strong decrease in the level of PSP, indicating that the level of PSP are also correlating with the reduced inflammation due to adsorption technique. So this is also can be used to see whether our patient are responding to this very interesting treatment with adsorption filters. And the difference was really statistically significant. The result from our clinical experience is that in this 6 ICU patient received CRRT with immunomodulatory cytokine adsorbed, we found an average of 26% decrease PSP was measured immediately before and after the treatment. These are very preliminary, but they are really also strongly significant. It's possible that a small amount of PSP might be removed by absorption of CRRT. So in conclusion, this pilot study, we found a trend for PSP to increase with the disease severity in COVID-19 patients. These results are preliminary, but PSP was significantly modulated, was higher in patients who died, correlating with what is known in the literature. So our data are according to the literature. We had a really good experience in the feasibility of a POC system in our hospital. It was really easy to use and very fast. And we think that the design of the Abioscope enables fast results, immediate decision to be taken in an urgent situation. And I thank you all for your kind attention. Thank you very much.
Thank you very much, Giuseppe, for your very good presentation. So I'll leave the floor now to Dr. Maria Petraki. Please go ahead. Thank you.
Hello. Thank you so much for inviting me and letting me join this very interesting webinar. I am Maria Petraki. I am an intensivist and an internist, and I'm the director of ICU in a high dependency unit at Mediterraneo Hospital in Athens. Mediterraneo Hospital is a private hospital in Athens located in Glyfada in the southern suburbs of Athens in the region of the Athenian Riviera. We are not a very big hospital, but what differentiates us from others is that we are a boutique hospital trying to make a point of care for each patient. Each patient has a tailored care in our hospital, whatever problem he or she has. What is important, I work, as I said before, in the intensive care unit and the high dependency unit. Our ICU has a capacity of 7 beds that can cover the intensive treatment of any patient. Actually, nowadays, we are covering patients from all over Athens, especially for patients that they have non-COVID disease or they have past 3 weeks of COVID disease and then now need extra care in ICU. The high dependency unit, which I work as well, has a capacity of 6 rooms and can cover more than 10 beds and can always be turned to an ICU bed. We are trying to use as advanced machines, and we're trying to use every sophisticated device that exists bedside to our patients. Therefore, Abioscope was a really important way to see how we can implement this to our patient. And of course, the medical and nursing team is well trained to take care of all these machines. I'm not going to say many things about sepsis. We all know that sepsis, if not recognized and managed early, may evolve rapidly into life-threatening septic shock and multiple organ failure. Of course, guidelines systematically emphasize the early recognition and aggressive management of sepsis, with combined early antibiotic treatment and support to prevent organ dysfunction. Currently, the confirmation of sepsis diagnosis is based largely on non-specific clinical signs, laboratory findings, and medical scores, which are usually obtained after sepsis onset. There is a big number of new biomarkers that are being compared to each other for the diagnosis of sepsis, but none of the studies up and until April 2021 discusses about the early detection of sepsis. We all know that what is really important is to find out which is the patient who is about to get into sepsis. And looking back to bibliography, we can find 5,367 new references since our previous review. We identified 258 biomarkers, 80 of which were new compared to our list. Sorry. What we decided to do in our hospital, we decided to do a pilot study trying to get some patients and trying to see when to use PSP. Therefore, in an unselected cohort of high risk for sepsis patients, we performed PSP to compare with another biomarkers that we were at the time using and clinical findings we usually use in the ICU. The pilot study was performed in the first quarter of 2021. We used 21 patients, 6 of them, they had confirmed sepsis, and 15 of them were confirmed with no sepsis. The method we used is the first run of PSP was performed when we started suspecting, based on clinical signs and or laboratory findings, that we were on the onset of sepsis. And after this, we decided to do a serial measurement of PSP, trying to find out whether or not the treatment we're using was on the right side or not. So on the graphics below, you can see the first run of PSP we performed. As I mentioned before, the first run of PSP was performed when we started suspected the sepsis based on clinical signs and or laboratory findings that we were on the onset of sepsis. And as you can see here, we did the same graphic for PSP, CRP, and white blood count, which are the biomarkers we are mostly used in our ICU. We were extremely happy to see that in patients with sepsis, the PSP measurements were quite high, showing to us that that PSP is a very good marker for showing us sepsis. On the same time, we could see that CRP and white blood count, there were occasions that were high, but the patient was not all the time septic. So that gives us the opportunity to think that PSP is a very good biomarker for finding sepsis, for the early onset of sepsis. We decided then to use PSP testing in the daily routine when we start running serial management of PSP early upon admission for all critically ill patients with high risk of complications and high risk to develop sepsis. Where? In our ICU, because most of our staff has been trained to be able to run PSP when it is needed, and also PSP provides in many of the cases actionable results, and it is very important that we can instantly get the results when we see severe changes in the patient clinical image. The process is very easy and it takes only a few minutes and is what we call bedside. We have found out that PSP in our hands has proven to be an essential tool to quickly and accurately diagnose sepsis. We are now starting earlier treating people for sepsis with remarkable results in the overall management of the patients and outcome of their stay in our ICU. As I mentioned before, I work in a private hospital and I should always think of cost-benefit medicine. We have found out that early diagnosing sepsis in our patient is a very good cost-saving tactic in our hospital that not only helps patients but also saves money. For the patients that we perform serial measurements, we can conclude that PSP is the only biomarker that accurately represents what we see clinically compared to other biomarkers. Now I'm going to present you the 3 case studies that I found more important, and really they helped us a lot, and I'm trying to show you how we used PSP. So the first patient is a 71-year-old female patient. As I mentioned before, we accept patients from other hospitals as well that they need ICU treatment. So this is a patient who was initially treated in the emergency department of a public hospital. She was suffering from severe metabolic acidosis. She was intubated in the emergency department there, and she was then transferred to ICU. From day 1 in our ICU, she has started hemodialysis and empirical antibiotic treatment, possibly thinking that she had chest infection since she was diabetic. We decided on day 11 of her admission to measure the PSP because we noticed that there was a change in the clinical image in terms of not improving and in terms of very low-grade fever. As I said, the patient, she was on continuous hemodialysis. So fever is not a clinical sign that can easily rely on when in ICU. On day 11, we did the PSP, and we found out that PSP was high, whereas both white blood count and CRP, they were not remarkably elevated. So we decided to escalate the antibiotic therapy to more advanced antibiotics. Was our tactic on the right path? Well, yes, it was, because first on day 14, we had clinically proven with the blood cultures that came back positive. And of course, later on, we found out that all three biomarkers, which are PSP and PCP and PSP, and CRP and white blood count, they were actually showing that the patient was getting better. In fact, day 14, the patient was, day 15, from our ICU, the patient was discharged from the ICU. So we have the case that according to the ICU, I have to say that we prevented a septic episode in this patient by escalating the antibiotic. In the second case, we have a 66 male patient. This is the case where the patient was in ICU 2 days before we did our first measure of PSP. Actually, that was a patient who was admitted due to acute respiratory failure type 1. So he was hypoxic, but at the same time, he had a cardiogenic shock due to an ejection fraction. He was on cardiac failure with an ejection fraction of less than 15%. On day 1, we started broad spectrum antibiotic. We then measured PSP for the first time when the patient was intubated on day 3. And we had the question, was that due to an infection, a new infection, or was this due to his cardiogenic shock? PSP showed us that he was not that type of patient that had a very severe infection, possibly leading to a septic shock. At the same time, CRP here and white blood count, they had these very small changes that are not specific for whether or not the patient is going to be septic or not. At that time, we didn't change the antibiotics, we kept them there, but we focused on treating the cardiogenic shock. And yes, the patient, he got better. And actually, the patient was extubated, and later on, he was discharged from the ICU to a rehabilitation center. And our third study is about a 44-year-old patient, a female one. She was treated due to COVID disease in another hospital. She stayed there for 67 days. She suffered a cardiac arrest there, and after this, a hypoxic ischemic encephalopathy. The patient, after 67 days, was admitted to our ICU because they had to evacuate beds for admitting new patients of COVID disease. And on admission, she was on no antibiotics, but when we examined her and we did all the tests for her, we found out that she was colonized with Klebsiella MDR without taking any antibiotic therapy. So yes, we carried on without any antibiotics, but we noticed that on day 7, we immediately changed the antibiotic therapy to targeted antibiotic 1 for Klebsiella because PSP measuring was high, and the patient had an immediate response to PSP and to other biomarkers, and the therapy lasted for 14 days, and finally she was discharged from our ICU. Conclusion: PSP is an accurate bedside biomarker. It is easily used for critically ill patients, and of course, we all know that these results justify further evaluation of the potential of serial PSP measurement in the early diagnosis, management, and clinical outcome of critically ill patients that develop nosocomial sepsis. Thank you so much.
Thank you very much. So thank you very much for all the comprehensive and very clear presentations. I would ask all the speakers just to turn on the cameras, please. Before going to discussion, I would like just to launch two small polls just to know what is your practice concerning the use of biomarkers at the website. Can you launch the polls room? Yeah. So do you use biomarkers in your regular practice? Select the following: yes or no. Please go ahead. Don't be shy. We don't know who is answering. Okay, I think we have more or less. Okay, very nice. So the next one is, can you just launch the other poll? Is what, obviously these are for those that answer yes. What do you use biomarkers for? And you can choose whatever you want. Exclude infection, diagnose infection, escalate antibiotics, stop antibiotics, or assess clinical response. Okay. So can we have the results? Quite interesting. 60, 23%, 23. Okay. So can you get back to see all the speakers? So I don't know if you saw the results, but anyway, I will tell you that the 75% of the people that is attending use biomarkers regularly at the bedside, and for what they use is it's not that the 32% to exclude, 60% to diagnose, 23% to escalate, 23% to stop, and 41% to clinical assessment. It's quite interesting. From the presentations, I saw that in a way, Professor João Gonçalves Perreira is more to rule out, Professor Castellano is more to assess severity, and Dr. Maria Petraki is more for diagnosis and clinical assessment. We have different ways of using PSP. And just to start the discussion, I will put two questions that are in the chat. Coming from Professor António Artigas. What is the value of PSP to diagnose early VAP, ventilator-associated pneumonia, if you have any experience on that or not? And another question also is if we can use PSP to predict acute kidney injury, which should start with the early VAP.
I have some experience.
Okay.
If you let me, I have some experience diagnosing VAP in patients with suspicion of VAP using the PSP approach. But I would like to note that our experience was mostly during this COVID pandemic, and the COVID patients may be different from other patients, and we have to take that in consideration. But when a patient has a suspicion of VAP, we don't. It's important to note that we don't use it in all patients, only in patients with a suspicion of VAP for any reason, mostly worsening oxygenation, also because climbing CRP without any other reason, and purulent secretions more or less, but mostly purulent secretions with worsening oxygenation. And the use of PSP it's at least in our experience is very well correlated with a benefit of using antibiotics, because when the PSP is low, when we found that the PSP was low, we refrained from starting antibiotics, and the patient did not get any worse. We have 70 patients that we evaluated with PSP, so there are not so many patients with that we have this approach, and so we can't say for sure that it's the best approach, but at least it works with until now it has worked. But I have to remind you that it's the COVID patients, and that may be different from others. We don't know for sure, but in patients with high CRP, we start antibiotics, and what we usually have found, and I show you in the graphics in the beginning of my presentation, was that patients I think that was 5 patients. I don't remember quite well, but I think that was 5 patients who actually have positive blood cultures, and the others. And when we start antibiotics, all came back with the bronchoalveolar lavage, also positive for infection. So that's our experience.
And concerning acute kidney injury,
this is a very interesting question. In our experience, the patient that develop acute kidney injury in presence of COVID-19, they had, as I showed you, very high level of PSP. To see if PSP is a predictive marker of acute kidney injury, we should have been measured earlier. But we have patients that were admitted to our unit already with an acute kidney injury. So the question is very interesting, but the answer is, I don't know. We should organize a different type of investigation, different type of trial in which you can measure PSP earlier, and then you can see if it's positive in the early stage of AKI. Also because this patient, they had an acute kidney injury requiring dialysis. So it's not a predictive biomarker. In our hand, it's a very good biomarker of the severity of the disease, in this case, the COVID-19.
Okay, so
can I just say
2 other questions? Yeah, please.
Just I wanted to mention my experience over the last week. We had 2 patients with VAP, and PSP was extremely high. It was more than 600, but we didn't need the PSP to assess whether or not it was a VAP, because it was so obvious. And I found that in my experience, it is more useful to see to find out on the gray zone whether or not someone has an infection, it's about to get septic. So when PSP is more than 600, it doesn't help me a lot. It usually helps me a lot when it is about 250 and the next day goes 300. That means that something is about to happen.
But the question is before the diagnosis, when does PSP begin to rise?
Exactly. That's why I'm saying when it's 600, you already have the diagnosis in front of you. You don't really need the PSP.
Okay. Then another question that I think can be to you is who performs the test, if it is the nurses, the doctors, and how do you decide which patients are going to perform the test? You perform every day to all of the patients, or what is the criteria just to perform the test? Can you start by you, Dr. Maria?
Yes, for us, usually we do it in the ward round. We made the decision And when there is a patient that has something changed or is not going well, you know, in ICU, not going well means that it's not getting any better. So when we have signs, this clinical sign, that either the oxygenation is getting worse or the blood pressure is getting low but not low as a shock, or the white blood count goes up but not much as an infection, then we make the decision to proceed to a PSP. And we always want to do a second one in about 48 hours if things are not, to see, of course, how things are going. Because on that day we're doing the PSP, we do something or nothing. If PSP is negative, we do nothing. But if it is positive, we do something. We escalate to advanced antibiotics more likely, or we proceed to extra tests like scans or whatever to find out what the reason is. This is the first one, when the decision is being made during the ward rounds. And of course, when we are not there, all the doctors during the ward round, something happens during the night, something sudden, then always the doctor has the ability, the knowledge to decide to do the PSP test.
And what about the other experts, João?
Well, in my ICU, everyone is able to perform the test. Usually, our trainees are the ones who do it, but also nurses can do it. The decision to perform a test is usually done in rounds, usually in the end of the morning, something like that. But sometimes when patients are admitted at another hour, if the patient has a suspicion of sepsis, but it's not clear that he has or has not. For instance, if the patient has a clear condensation, a clear community-acquired pneumonia, or it's has a purulent discharge from his bowel, we don't need PSP. But if the patient has a suspicion of sepsis, but we are not certain, we perform the PSP in order to be able to discriminate the patients with inflammation from patients with sepsis, and that's the point when we found it more useful. Or else during rounds, when in situations such as that, especially when the hospital-acquired infection is suspected.
And in Italy, or do you do, Castellano?
Yes, in our experience, we had the system in our nephrology unit, and it was very easy to use, and it was performed by our nurse or also by our trainees, nephrologist specialist without any problem. And we usually perform early in the morning. And besides that, after we receive all the other values from the lab, from the patient, and then we decided on that basis, like in ICU, whether apply or not the cytosorb treatment. So it is easily to use in the morning, and then you can have a discussion with these very fast results. And this is very easy to use and easy to have over there, I mean.
So just to close, this is a very interesting question from Frederico Gordon that I would like from you three to have short answer. Do you think there is enough evidence to make clinical decisions based on PSP determination? And how many PSP determinations do you recommend in a patient to ensure that sepsis is to rule out? What is, if the negative predictive value is that high that you can safely rule out infection, having a pretest probability around 40%, let's say. So one short question from all of you, because we have to finish. Sorry. Can start with Maria.
Very difficult question. Very difficult because we need more data to find out, to rule out. Or I think we are now trying to find out what we're doing. In our ICU, we're trying to do two measurements of PSP. in order to rule out sepsis within 24 hours. And yes, this is what we're trying to do. And the other thing is that once PSP is high, we don't do the second one immediately in 24 hours, but we can delay it because we want to see the trend and how well the patient goes.
Thank you. For a short question, another short question, Giuseppe Castellano.
I think that at least our experience is with the COVID-19 patient. So I suggest that when you have an admission of a patient with COVID-19 or suspect of COVID-19, and then you measure PSP and is very high, in our experience is a patient at high risk to die, and you should particularly have you should take care of it. But our experience is only with COVID-19 patient, because as I told you, you can really discriminate the patient that went to ICU or the patient that remain in our unit with a very low activity of COVID-19. And this is our experience in COVID-19. And really, if you can measure it, you can really discriminate the two populations.
Thank you. Finally, João.
Well, I think the most benefit of the PSP and the most proven value of PSP is in patients when you are in doubt. I will suppose something like the pretest of between 40 and 60% of possibility, and in that case, PSP may be discriminate between patients with infection and not infection. But I will, and that's most what we do in those patients. But I will also like to point one other point that I think is very important. The range of results of the PSP is very large, and you want to go from 0 to 600, and the cutoff values in the ICU, in the emergency department, in the outpatient may be different, and because you in the ICU you have lots of noise, lots of causes for inflammation that may increase all biomarkers, and the point that this range is very large is maybe benefits for the use of this biomarker. Also, only for ending, I just like to remind that no biomarker can be used alone, because a good biomarker can make a good doctor better, but can make a bad doctor even worse. It's an axiom, but I think it's very true.
Thank you very much. I have to thank all the speakers for very clear presentations and the different ways of using PSP at the bedside. Also, thank you the attendees, because they also make very nice questions, good discussion, and also these polls saying 3/4 use biomarkers at the bedside, but for very different things. The majority for the diagnosis, but then to exclude the infection, to escalate, stopping around 1/3, 1/4, and to assess response almost half of them. Thank you very much for your participation, and good afternoon to you all.
Thank you very much for inviting me.
Bye.
Thank you,
Bye.
Mr. Chairman. Thank you, colleague. Bye-bye.